Hi, I'm Penny Simkin, and today I'd like to talk with you about some of the trends in maternity care that have brought us to where we are today. And I want to make sure that we know where we are today. So I think I'll begin by just talking about the goals of maternity care are certainly excellent outcomes in terms of health of mother, health of baby, and no long-term problems. So in our efforts over the years to improve maternity care and achieve those goals, we've developed, in the United States, we've taken the tack of wanting to improve maternity care with three basic approaches. More technology, improved technology, drugs or medications, and surgery. And the idea has been that the normal birth process needs improvement, can be improved with those three. I call them TDS or TDS. So you can tell I have a slight bias here. Well, in the beginning, when these things began to be introduced, they were helpful because we know that all outcomes are not perfect. And the use of technology to try to identify problems before they arose, for example, ultrasound, to try to see whether the position of the baby, to try to anticipate the size of the baby, to pick up some congenital defects, that sort of thing could be very helpful. The use of electronic fetal monitoring to try to keep track of the baby's pulse during labor and how the contractions affected the pulse. Those were thought to be very brilliant ways to keep track of the baby's well-being, and if the heart rate differed in particular ways, they would know the baby was in trouble and they would do a cesarean to rescue the baby. So that in the early days, some of those things were helpful, but we did find that it was hard to, there's a subjective element to all of those, to ultrasound, and to interpretation of fetal heart rate tracings. So we found that cesareans would increase with the use of these devices and technologies. So the effort has been to improve the technology, fine-tune it, but we're still not at a place where we've taken all the subjectivity out of it. The use of medications and drugs, we have everything, you know, for infertility, for blood pressure, for starting labor, for slowing labor, for speeding up a labor. We have drugs for medical problems, and many, many others. I can't even think of them all, but we can alter the course of labor hugely by the use of drugs. Oh, pain, duh. Of course, drugs for pain. So all these drugs have side effects. There's a trade-off in the use of all of these. So would it be good to be selective and use these for the people that need them most or where there's a clear problem? Or is it a good idea to use them on a widespread basis with the idea that it would prevent a problem from occurring? So the use of drugs. And now we go to the use of surgery. Surgery meaning cesareans, of course. Episiotomies, that's an incision to enlarge the vaginal outlet. Forceps deliveries, they're considered to be surgical. Breaking the bag of waters is a surgical procedure. Vacuum extraction. So the added use, the increased use of surgery with the hope of improving outcomes. So we now have one woman in three is having her baby by cesarean. And we aren't finding improved outcomes. What has happened is we have reached the point of no return, or we've reached the point of diminishing returns, I should say. And by using things that should be used selectively to a large part of the population, we're now getting worse outcomes. The United States, we're the only industrialized country where there's an increase in maternal mortality, mothers dying. I mean, it's a low number, but it's on the rise. Should not be. More prematurity, more infant mortality, more perinatal mortality. So with all the technology, the surgery, and the medications we're using, we're not improving outcomes. So there's something wrong with this picture. Now, so where does that leave you as the consumer, as the expectant parent, or someone who's trying to improve the course of care in your own institution? Well, I think what we need to do here is to think about the two key elements in a decision that will make a big difference in the kind of care you get and whether you're going to be subjected to overuse or you're going to be part of overuse of these technologies. The two big decisions that have to be made here are where are you going to give birth and with whom? Who is going to be your care provider? Those two choices are going to pave the way in one direction or another toward overuse or underuse. So the places, what do we have for birth? In terms of place of birth, we have hospitals that by far the most common. We have independent or freestanding birth centers, and we have the home birth. And those are, the last two are out-of-hospital birth centers, or birth options. But let's talk about the hospitals first. There is such a huge variation in hospitals. In the state of Texas, I was reading that within miles of each other, there is a hospital with a cesarean rate over 50%, and one just a few miles away with a cesarean rate of 20%. Wouldn't it be good to know the cesarean rate at the hospital that you're investigating before you decide? You're going to, you're almost destined to have one in places that use them casually and don't wait for a medical reason for it. And this is true all over the country. We have wide variations in cesarean rates. And there are some good reasons. Some of the teaching hospitals have more sick people, more high-risk people. They have to do more cesareans. So there are some explanations there. But in many cases, there is no good reason for a hospital having a cesarean rate, above 25%, yet most do. Then, so that's the hospital. If you have any choices, and many people don't, there's one hospital for miles around, and they're kind of stuck in that hospital. At another talk, I'll have to talk about what you might do in a situation like that. But I want to follow up on the out-of-hospital births. If you give birth in a freestanding birth center or a home birth, you're probably going to have a midwife as your care provider. So you're choosing a type of care provider along with the place of birth. And in cases like this, the considerations you want are what kind of backup arrangements are there, because sometimes a birth starts out very normally and safely, and then problems can arise. A question to ask of that care provider for that setting would be, what would we do if a problem arose? Where do you take me? What is a good hospital to use for backup? Do you have a good arrangement with the physicians who would be looking after me? So, but we do know that starting off out of hospital means that you're not going to get any interventions that you do not need. So whereas starting in the hospital, you may be subjected to interventions that you don't need. And some people are going to get mad at me for saying that, but it's true. And you may have to, a lot of procedures are routine, but they don't have benefit to them, and that's been proven. So if the decisions you make to start off, good hospital, good home birth with good backup, or good birth center with good backup, those are very good decisions. And then the care providers that are instruments of those places, that themselves are reluctant to do cesarean surgery, for example, that are reluctant to use unnecessary interventions, those are going to make it easier for you to have the kind of birth that is safe and satisfying. Thank you very much.